So this is chapter 32, and this is care of patients with cardiac problems. So again, the concepts for this chapter is perfusion, as it should be, but some interrelated concepts for this particular chapter, care of patients with cardiac problems, includes gas exchange, comfort, and immunity. So let's review a little bit about our pathophysiology. I always like to do that. Heart failure. What is the pathophysiology of heart failure? Here's your overview. It is a chronic health problem. The major types are left-sided heart failure, right-sided heart failure, and high output heart failure. And we will discuss these. So let's look at left-sided heart failure first. This was formerly known as congestive heart failure. Most starts with the failure of the left, and it will progress to failure of both the right and the left ventricle. Some of the symptoms are restlessness, confusion, orthopnea, tachycardia, dyspnea with exertion, fatigue, cyanosis, pulmonary congestion with cough, crackles, wheezes, and blood-tinged sputum. Now, you know you have two separate pumping systems. You've got the left side and you've got the right side. Most starts, as I said, with failure of the left and progresses to failure of both sides. The causes of left-sided failure include hypertension, coronary artery disease, and valve disease. And it's formerly called CHF because not all cases involve fluid accumulation. You have acute, chronic, mild, and severe. The symptoms are similar but more pronounced as they get worse. Systolic heart failure is a reduced ejection fraction. This is a reduced amount of blood ejected from the heart. The normal ejection fraction is 50 to 70%. When it falls below 40%, you're classified as having heart failure. The decreased ejection of the blood causes tissue perfusion diminishment, and blood accumulates in the pulmonary vessels. If an EF, or ejection fraction, is below 30%, they're candidates for an ICD, an implanted defibrillator, because they are at high risk for sudden cardiac death. Okay? Diastolic failure is when the left ventricle is unable to relax during diastole. And when it can't relax, it stops the ventricle from filling. So it just halts the filling of the blood into the ventricle. So the ventricle has nothing, it won't fill. So if it's more than 40%, if the EF is more than 40%, it may indicate that they have left ventricle diastolic heart failure, but the ventricle is still less compliant than it was, so they have heart failure. Let me say that again. In diastolic heart failure, the left ventricle is unable to relax during diastole, which prevents the ventricle from filling. You may have an EF more than 40%, but it's still not compliant. The ventricle is not compliant, so it's not pushing the blood out. Okay? Now let's talk about right side heart failure. This is failure of the right ventricle. Now what causes this? Well, when the left ventricle fails, it can cause the right ventricle to work harder and ultimately fail. or the right ventricle can have an infarction, particularly on the in the right coronary artery. So it can affect the right ventricle. And pulmonary hypertension. This can cause a major problem with the right ventricle, pulmonary hypertension. The right ventricle cannot completely empty. So it increases the volume and the pressure in the venous system, and this one causes the peripheral edema, not so much in the lungs as it is in the periphery. So they would get nausea, and they may have to get up at night to pee. They would be very fatigued. They would have increased peripheral venous pressure. They might have ascites. They may have an enlarged liver and spleen. This is where the jugular veins can become very distended and have weight gain, of course, and edema, and anorexia and GI distress. So this is right-sided heart failure. High output failure means that the cardiac output remains normal or above normal, but this is caused by um, an increase in metabolic needs or a hyperkinetic condition, and this can be found in people who have hyperthyroidism, people who have anemia. They have to, their heart rate's beating faster to because of the oxygen carrying capacity, and high fevers. Of course, that's a higher metabolism, and septicemia. So in septicemia, you may see somebody who has high output failure because they need more than they have, and they have a normal cardiac output, but they need more than that. So that's high output failure. So this is classified. The heart failure has a classification and staging. Patients at high risk for developing heart failure, that's a class 1. Patients with abnormalities or have remodeling of the heart after they have a heart attack. They have not developed heart failure symptoms, but they could have them. This is a class 1 also. Then you have patients with current or prior symptoms of heart failure. This is a class 2. Then you have people who have refractory end-stage heart failure, and that's a class 4. So it just goes in classifications according to the severity. And this is the New York Heart Association. Well, how does the body compensate? Well, obviously, we know that the heart rate increases to meet the body's demand for more oxygenation. It's a pump. This is what it's for. And the blood vessels are there to deliver oxygen and nutrients to the cells. That's what it's supposed to do. So, when you have a problem, the sympathetic nervous system will be stimulated, and the renin-angiotensin system, the RAS, will be activated, and then there will be other chemical responses in the baroreceptors, and all of these other compensatory mechanisms will come into play, and it can cause the hypertrophy of the cardiac muscle. It can cause it to get bigger because it has to work harder, so it loses its shape. So, what causes this? Systemic hypertension. When a person has high blood pressure, it can cause the vessels to become compromised, and it can cause heart failure long term. Some people who have an MI can also develop heart failure because of the loss of the muscle. Structural heart changes due to bacterial infections or to drugs, those sorts of things can also cause heart failure. The right-sided heart failure, in absence of left-sided heart failure, is often the result of pulmonary problems. I would like very much if y'all would know that, please, okay? This is a very important factor here. If people have right-sided heart failure but no left-sided problems, this is the result of pulmonary problems. There are a lot of people in the United States who have heart failure, 6.5 million people. And a lot of that is due to, as we said, is due to hypertension and to coronary artery disease. Most common reason for hospitalization for people who are over 65 years. It's a cumulative problem. It ends up over the years, the heart just can't compensate, or the body can't compensate anymore. So it's more common in African American individuals under 50-year old than in the Euro American population. So, what are your symptoms? Well, you're going to do a history and you want to know what their symptoms are. You want to know if they've had a history of heart conditions. Do they have exertional dyspnea? Have they recently stopped tolerating activity because they get short of breath? Do they get up at night when they're lying flat in the bed, or are they using a bunch of pillows to sleep upright in? Or do they sleep in a recliner? Do they have paroxysmal nocturnal dyspnea? They suddenly awake with shortness of breath after falling asleep and they have to sit up or dangle or walk. These are changes that you want to know about. Particularly left-sided heart failure, they will have dyspnea, exertional dyspnea or paroxysmal nocturnal dyspnea. Left side. They're going to have fatigue, weakness, arm heaviness, chest pain or palpitations, skipped beat, and a fast rate. That's compensatory. Causes include, of course, hypertension, CAD, and valve disease. Remember that it can be acute, chronic, mild, or severe. On the right-sided failure, you're going to see jugular vein distension, increase in the abdominal girth from ascites, dependent edema when they're lying down, edema, they may get edema in their back, or they stand up, they get edema in their feet, hepatomegaly, their liver gets bigger, and they may have a hepatojugular reflux. Ascites, we already said, that would be the abdominal girth, and the weight here, the weight, you better know this, weight is the most reliable indicator of fluid gain or loss. What causes right-sided failure? Do you remember? Left ventricular failure will eventually cause right ventricular failure, an MI in that area, and the biggie is pulmonary hypertension. So when we're doing our assessment, we're going to recognize some cues that lead us to recognizing heart failure. Of course, you're going to do your lab assessments. You're going to particularly look at the serum electrolytes that you're going to pay attention to, particularly with potassium. Hemoglobin hematocrit, you're going to want to know their level for perfusion of the oxygen. The BNP, which is B-type natriuretic peptide, a BNP, that's produced and released by the ventricles when the patient has fluid overload as a result of heart failure, and the normal is 100 or less. If it's severe heart failure, it can be over 900, and I've seen them over 1300 before. Urinalysis you're going to look at. You're going to look for proteins in the urine, anything that might show up abnormal, and also their ABGs, because you want to know what their gas exchange is. You want to look at their chest x-ray for cardiomegaly and pleural effusions. Echocardiography is the best. The echo is the best diagnostic tool for heart failure, and it is non-invasive, and it shows the EF. It will calculate the ejection fraction, and that's very, very important. And I really hope that you will get this correct should I ask a question. Echocardiography is the best diagnostic tool because it shows the EF. And then, of course, there are other studies they can do to look at the function of the heart, the MUGA, and the radionucleotide studies are also done. So, how do we also look at this? Here are some cues again. If you're working in the unit, you will know these very, very well. Sometimes you'll be out on the cardiac step-down unit and you'll need to know these too. If they go to the cath lab, they will do hemodynamic monitoring. They will do it in the units also with the Swan-Ganz. They will use, this is a direct assessment of the cardiac function and the volume status. So remembering that the ejection fraction is the volume of blood pumped upon each beat. So they may do a PAP, a pulmonary arterial pressure. They may do PAWP, which is a pulmonary arterial wedge pressure. These will tell you how much fluid is in how much problems they are having with the fluid overload according to the values that you see. This is not done on the floor, so I'm not going to ask you to know all that. So what I'm asking you to know is what the left ventricular ejection fraction is. The normal, these are the values that I want you to know. The normal is 55 to 70%. That is how much blood reaches the systemic circulation with each heartbeat. Right-sided EF is the normal is between 45 and 60%, and it's how much blood reaches the lungs to be oxygenated with each heartbeat. Okay? Important stuff. So when we look at our cues and we look at our, we're going to analyze them, and then we're going to say, well, okay, what are we going to do? How are we going to treat this? What is our goal here? Well, obviously, we want to prioritize the hypothesis related to decreased gas exchange due to that ventilation perfusion imbalance, because there's not enough perfusion going out to oxygenate the cells. And you have the potential for decreased perfusion due to inadequate cardiac output. You have potential for pulmonary edema due to left-sided heart failure. Now, there are drugs, lots of drugs that we can give to help this. One drug is called the natriuretic peptides. This is also called nesiratide. These are used in patients with acutely decompensated heart failure, and it will improve the hemodynamics and the dyspnea, and it is approved in the United States and several other countries for patients with acute decompensated heart failure, and it will combat the cardiac stress because it reduces the blood pressure and helps with ventricular fibrosis. So we're going to look for something that will increase our gas exchange, increase perfusion, and prevent or manage pulmonary edema. So we're going to make sure that the gas exchange and the carbon dioxide level is within normal limits. You have to monitor their intake and output. Should be between 1,500 to 1,800 milliliters a day. They must weigh using the same scale every morning before breakfast. They need to sit and sleep in an upright position. They may need nitrates, which will cause the um, vessels to dilate, which will allow more blood to flow through. They may be given Lasix or some kind of diuretic to relieve some of the volume that the overload. Certainly oxygen. They may need ACE inhibitors for the blood pressure and to protect the kidney. They may need digoxin to strengthen that stroke volume, and you definitely want to decrease their fluids, sodium restriction, and sometimes people who have sleep apnea will improve with CPAP. And sometimes they even need, for really, really severe end stage heart failure, they may use ventricular assist devices. They may have a mechanical pump implanted which works with their own heart, and usually that's done to until they can get a transplant, or it can be used long term, but it's a very confining situation. So when the patient goes home, the patient with heart failure goes home, they will need to know how to do home care management. So that means they're going to have to follow their diet, restrict their sodium, usually around 2 to 3 grams daily, which means they would eliminate all table salt. They would, of course, monitor for fatigue, angina, or their activity intolerance and any changes in mental status. You would assess their nutritional status. You're going to look for safety hazards, especially those related to oxygen therapy. You're going to assess the understanding of the illness and its treatment, including signs and symptoms to report to the primary health care provider. And also, whoever's going to be taking care of them at home, you need to assess their coping skills also, because this is going to be something these people are going to need help at home with their care. And social support would include the family and maybe home health care services. Those would be good things to think about. So when you're assessing whether or not what you've done has met your outcomes, you're going to look to make sure your patient has adequate pulmonary tissue perfusion. That is the key here, that they are getting tissue perfusion as they should. And that would mean that they would have increased cardiac pump effectiveness and to be free of any pulmonary edema. So that mainly means that they're going to be at optimal cardiac output and their ejection fraction. So let's switch gears just a bit here and talk about valvular heart disease. The pathophysiology, we're going to be talking about mitral valve prolapse, aortic stenosis, and aortic regurgitation. So let's first look at mitral stenosis. Rheumatic fever is the most common cause for mitral stenosis, and that's why everybody who has strep must be on an antibiotic. Mitral stenosis results from a rheumatic carditis, like a rheumatic fever from strep throat, and it causes the valve to thicken and it becomes very stiff. Now, the congestion, it causes pulmonary congestion and right-sided heart failure first. And then later, that preload will decrease and the cardiac output will fall. People who have mild mitral stenosis may never know it. They may be totally asymptomatic. But if they have really bad mitral stenosis, they may need to have surgery and have a valve replacement. Symptoms would include shortness of breath on exertion, dyspnea on exertion, orthopnea, and paroxysmal nocturnal dyspnea, and palpitations, and a dry cough. If they have mitral regurgitation, that is an insufficiency. It's caused by mitral valve prolapse. Again, rheumatic heart disease can cause it. They can get infective endocarditis, an MI, and other connective tissue diseases, and some dilated cardiomyopathy that can happen related to some certain conditions. It is a slowly progressive problem, and the patient may be symptom free for years and years and years. They will develop fatigue, chronic weakness, anxiety, atrial fib, and the respiratory changes that we talked about, the dyspnea and the orthopnea, can also occur. Now, mitral valve prolapse is when the leaflets on the valve will get bigger, and then they prolapse into the left atrium when the heart beats, when it contracts. There's a family tendency for this. Most people, my sister was asymptomatic. This is what she had. Some people will have palpitations. She did have that rapid heart rate that they controlled with the calcium channel blocker. And sometimes they have chest pain and exercise intolerance. And sometimes you can hear a click when you listen to the heart. They would have a mid-systolic click and maybe a murmur. So aortic stenosis, this is the most common valve dysfunction in the United States. It is a disease of wear and tear, so you can see this happening through atherosclerosis, degenerative calcification, and these are the major causes in the older adult population. It can cause right-sided failure late in the disease because, first of all, the left ventricle will fail, and then the blood will back up into the left atrium, and the pulmonary congestion will become worse, and then it will then develop right-sided heart failure will develop. When the valve becomes 1 centimeter or less, surgery is urgently needed. Causes include congenital, which is the primary cause, and rheumatic aortic stenosis plus the older generation. And they will develop a murmur. It's a systolic murmur. Now, aortic regurgitation, which is insufficiency, can result from non-rheumatic conditions, and these people can be asymptomatic for many, many years. What happens is the flow of the blood from the aorta goes back into the left ventricle, and it can be caused by infective endocarditis, it can be congenital, and it can be caused by hypertension. Symptoms here, if they are having symptoms, would be exertional dyspnea, orthopnea, paroxysmal nocturnal dyspnea, and palpitations. Now, this can be a sudden illness or, as I said, slowly developing symptoms over many, many years. So you're going to ask them about attacks of rheumatic fever, or if they've had infective endocarditis or any IV drug use. The blood flow from the aorta, because the leaflets of the valves do not close properly during diastole, allows that blood from the aorta to flow back into that left ventricle during diastole. So the left ventricle gets bigger and bigger, and it gets larger to accommodate that greater blood volume, and it will lose the contractility that it had. And this will usually, as I said, it results from non-rheumatic conditions such as the infective endocarditis, etc. Hypertension and Marfan syndrome is also causes this. You would find it on echocardiography, chest x-ray, and ECG. So, what are we going to do? What interventions are we going to take? Well, non-surgically would be drug therapy and rest. Remember, pulmonary or systemic congestion is what you're going to see. So you're going to do drug therapy such as diuretics, beta blockers, ACE inhibitors, digoxin, and oxygen, some nitrates, vasodilators, some antibiotic therapy before dental or oral procedures, and good oral hygiene. Surgical would be open heart surgery, similar to a CABG, coronary artery bypass surgery, grafts, and they would put in a prosthetic valve. That could be synthetic or it could be biological, which is a pig or a cow. This shows you some pictures of valves, and these are the heart valves that can be used. So what did they do at home? How do they take care of themselves at home with aortic regurg? Well, they're going to need to know about drug therapy because they're probably going to be on beta blockers and diuretics and maybe the ACE inhibitors, and they may even be on oxygen at home. So you're going to teach the importance of that prophylactic antibiotic therapy before any invasive dental or oral procedure. And they need to demonstrate that they know how to do appropriate oral hygiene because these patients can develop from these procedures, oral, dental care, and whatnot. They can develop endocarditis from that. So they have to be very careful. You're going to watch for atrial fib because that will decrease the cardiac output, remember. And they may give low-dose amiodarone to slow the ventricular response if they are in atrial fib. The American Heart Association, Mended Heart Association provides information about valvular disease for your patient. Speaking of infective endocarditis, let's talk about that now. This was previously called bacterial endocarditis. This is infection of the endocardium. It's caused by viruses, bacteria, and fungi. The most common infective organism is strep or staph. People who abuse IV drugs, have had valve replacements or alterations in their immune system, or have structural cardiac defects are prone to getting infective endocarditis. It can be, they call it vegetation. The ports of entry are the oral cavity, the skin, infections, surgery, and IV line placement. What you would see is heart failure. The most common complication of infective endocarditis and arterial embolization is a major complication in up to half of the patients who have infective endocarditis, and that's due to fragments of vegetation. That's the bacteria that settles in there, and it's called vegetation. That vegetation will break loose and it will travel at random. So they can get little petechiae, they may get systemic embolization, they may get splinter hemorrhages, and they may have nodes on their hands and the soles of their feet, and lesions, their flat reddened maculae on their hands and their feet, little red raised areas. And they may also have what's called Roth spots, which are lesions that get in the eyes around the retina. And of course, they'd have positive blood cultures. So let's take some action here. What are we going to do? Well, first of all, we're going to make sure that we have looked at the diagnosis, and the most reliable criteria for diagnosing pericarditis is positive blood cultures. They would have a new regurgitant murmur and evidence of endocardial involvement by um, uh, echocardiography, which would be, this is where they would do the TEE, the going down into the esophagus to look, because they could see the vegetation much better there. Surgical removal would be removal of the infected valve and repair of the injured valves in the chordae tendineae, or draining the abscesses from the heart. They may also non-surgically give antimicrobials, and that treatment would last 4 to 6 weeks, first in the hospital and then at home. So as I said, they may need antibiotics at home, and you're going to, when they do transition home and they have this diagnosis, you must make sure that they know to use proper oral hygiene, and especially let the doctor know or the dentist know when they go to for any cleanings or for any dental procedures. So now let's talk about pericarditis. This is the inflammation of the sac that encloses the heart. And this can be associated with infections uh, after an MI. That is called Dressler syndrome. It's due to inflammation where the tissue has been compromised. And then a post pericardiotomy syndrome, and acute exacerbations of systemic connective tissue disease such as lupus or arthritis or something like that. Now, you may hear a pericardial friction rub. It's a scratchy, high-pitched noise. It's very painful. Oh, it hurts. You'll think they're having another heart attack or something, or they're having angina. They will have an elevated white blood count. So you would look for that. That would be a cue. They're going to have fever, and uh, all leads of the ECG will have ST elevation because of the inflammation. This is treated with NSAIDs and corticosteroids. Now, they may develop pericardial effusion. It's kind of like a pleural effusion, except this would be around the heart, and it's very painful. So you're going to treat the cause of it. You're going to treat the cause of the pericarditis, whatever they see what has caused it. If it's from an MI or if it's from infection, they would treat that. And remember this, though. If that space between the layers of the pericardium fills up with fluid and compresses the heart, it can cause a tamponade. So this is something you have to watch for. So they are very much at risk for the cardiac tamponade with the pleural, not a pleural, but a pericardial effusion, and that would be when there's an excessive amount of fluid within the pericardial cavity. And what they would do would be a pericardiocentesis, which is similar to a thoracentesis, except it drains the fluid from around the heart and not the lungs. This will remove fluid and relieve pressure on the heart. And they insert a pericardial needle into that pericardial space, and they will withdraw the fluid. They Sometimes, and I have seen this happen, and yes, I've helped with this before too, pericardial drain may be placed for somebody who has an ongoing problem and they keep building up fluid. They will put a pericardial drain into that space. And of course, usually they'll send specimens to the lab. So, this, of course, is a cardiac emergency, and they will do this at the bedside if they need to. Sometimes they will do it if there's a blood around the heart, say after a cath and something happens, or if it is due to fluid, they will go in and they will put the needle and they will aspirate, and it can be very dramatic, very dramatic. Okay, now let's talk about rheumatic carditis. These, this is a sensitivity after an upper respiratory infection, and when they have strep. Um, they get lesions in the endocardium, and that causes inflammation of the valve leaflets, and they develop these Ashkoff bodies. The primary prevention for this is extremely important. That's why any infection with um, um, rheumatic fever or streptococcal infections, they must be treated with antibiotics without fail. And they're usually treated with penicillin or erythromycin. Now, these Ashkoff bodies are nodules that they find in the hearts of individuals who have rheumatic fever, and they result from inflammation in the heart muscle, and they're very characteristic of rheumatic heart disease. Okay, cardiomyopathy is can be subacute or chronic, and it's a disease of the cardiac muscle. These diseases have many, many causes, signs and symptoms, and treatments. Um, Subacute or chronic types are dilated cardiomyopathy, hypertrophic cardiomyopathy, restrictive cardiomyopathy, and arrhythmogenic right ventricular cardiomyopathy caused by dysplasia. So, what happens? In cardiomyopathy, the heart becomes enlarged, thick, or rigid. In rare cases, the muscle tissue is replaced with scar tissue. So as it worsens, as cardiomyopathy worsens, the heart becomes weaker and it's not able to pump blood through the system or maintain a normal electrical rhythm. This can lead to heart failure or irregular heartbeats called dysrhythmias. In turn, heart failure can cause fluid to build up in the lungs, ankles, feet, legs, and abdomen. So, talking about the types, we're going to talk about each of these, okay? In dilated cardiomyopathy, the reason is often not known. About 1/3 of the people who have dilated cardiomyopathy inherit it from their parents. Hypertrophic cardiomyopathy. It's usually inherited, and it's caused by a mutation or change in some of the genes in the heart muscle proteins. It can develop over time because of high blood pressure, aging, or other diseases such as diabetes or thyroid disease, and sometimes the cause just flat is not known. Restrictive cardiomyopathy. Well, certain diseases, conditions, and other factors can cause this, including amyloidosis, which is a disease in which abnormal proteins will build up in the body's organs, which includes the heart. Connective tissue diseases or disorders. Hemochromatosis, this is a disease in which there's too much iron builds up in the body, and the iron is toxic and can damage the organs. Sarcoidosis can cause this. It's a disease that causes inflammation and can affect organs in the body. So, this is an abnormal immune response, and it causes lumps of cells to form in the body's organs, and that does include the heart and also the lungs. Some cancer treatments, such as radiation and chemotherapy, can cause restrictive cardiomyopathy. And the arrhythmogenic right ventricular dysplasia is an inherited disease. So let's recognize our cues here. When we're doing our assessment, we are going to particularly look for findings which are dependent upon structural and functional abnormalities, such as um, alcohol that can cause it, toxins such as poisons and heavy metals, complications during the last months of pregnancy, ischemic heart disease, heart attack, high blood pressure, diabetes, thyroid disease, viral hepatitis, and HIV. And illegal drugs such as cocaine and amphetamines, and some medicines that are used to treat cancer. Sometimes it will be due to viral infections that inflame the heart tissue and the heart muscle. So you're going to teach the patients to report any palpitations or dizziness or fainting which might indicate a dysrhythmia. They may be having little bursts of V-tach, or they may be having paroxysmal um, runs of atrial tachycardia, anything that can cause them to have dizziness or fainting. So, our main goals for treating cardiomyopathy is to control the signs and symptoms so that people can live as normally as is possible. We want to manage any conditions that we just mentioned that can cause or contribute to the disease, and reduce complications and the risk of sudden cardiac arrest. We also want to stop the disease from getting worse. And there are methods to do that by teaching your patient and by making sure that you are assessing them for any signs and symptoms. So, to do that, we are going to look at types of treatment. Of course, you'll look at heart healthy lifestyle changes. Some medications would include beta blockers, calcium channel blockers, and DIG. These are examples of medicines that can slow the heart rate. Um, Beta blockers and calcium channel blockers are also used to lower blood pressure. Uh, Non-surgical procedure called alcohol septal ablation can be used to treat cardiomyopathy, and that's where they put ethanol or alcohol is injected through a tube into the small artery that supplies the blood to that area of the heart muscle, and the heart that alcohol will kill those cells and will cause that thickened tissue to shrink back to a more normal size, which should allow blood to flow freely through the ventricle, which again should improve their symptoms. That's a non-surgical management. They might do surgical management, which would include a septal myectomy. This is open heart surgery, and it's used to treat people who have hypertrophic thickening cardiomyopathy with severe symptoms. It's generally used for younger patients and for people whose medicines are not working well. What happens is the surgeon removes part of that thickened septum that's bulging into the left ventricle, and that will improve the blood flow through the heart and out to the body. That removed tissue does not grow back, and it if they need to, the surgeon can go in there and repair a mitral valve if they need to. Or septal myectomy is usually very successful and allows people to return to a normal lifestyle. Surgeons can also place several types of devices in the heart to improve the function and symptoms. They might do cardiac resynchronization therapy, which helps coordinate contractions between the heart, the left and right ventricles. They might put in implantable cardioverter defibrillator to control life-threatening dysrhythmias that may lead to sudden cardiac arrest. They may also do left ventricular assist device to help the heart pump to the body. It can be used as long-term therapy or as short-term therapy for people who are waiting for a heart transplant. And also they can put in a pacemaker. This is to help control dysrhythmias. And it uses electrical pulses to prompt the heart to beat at a normal rate. And of course, what they do depends on the type of cardiomyopathy, and the ultimate cure is, of course, a heart transplantation. Now, this shows you on this slide how they actually do a heart transplant. It's the last resort treatment for people who have end-stage heart failure. End-stage means the condition has become so severe that all treatments other than transplant have failed. And this is the procedure they use, and it's pretty amazing. Let's do a case study. We have 5 slides here related to this case study. A 53-year-old client was admitted 2 days ago for recurrent exacerbation of heart failure. He weighs 237. He's 5'8". He has an IV access in his left forearm and is on oxygen already at 2 liters per minute per nasal cannula. He has, upon entering the room, the nurse notes that he's sitting on the side of the bed. He's sweating and he is experiencing shortness of breath. He reports just using the bathroom, and his nasal cannula is on the bedside table. So what is the very first thing you're going to do? And I hope to Pete that you say B, because that's exactly what you need to do. You need to put his oxygen back on. He's just exerted, and he's having an exacerbation of his heart failure. He needs that oxygen. And there you have it. He's exerted himself and he's been without his supplemental oxygen. So you're going to replace his nasal oxygen. Now, he has a history of heart failure, so you know he may require supplemental oxygen. He may even use it at home. So taking his vital signs, you'll do that after you get his oxygen restored. And if he wants to sit up, he can go to in the bed and raise his head up. And at this point, you do not need the rapid response team. Okay, this is the second slide, or the second of the 2 of 5. 15 minutes after replacing the nasal cannula, the client's oxygenation saturation is 97%. What is the appropriate nursing action? What do you think? Does he need to deep breathe? Do you need to call the doctor? Do you need to increase his oxygen? All of those are exactly no. You're going to continue your assessment. You've got his oxygen on. He's not short of breath. He's resting. So now his oxygen level's up, and it shouldn't be increased because he's doing good, and he doesn't need to take deep breaths because he's normal. He's not short of breath. So that's your answer, is continue your assessment. So after the assessment, your documentation is that he has jugular vein distension. He has 2+ edema in his feet and ankles. He has swollen hands and fingers. He has a distended abdomen. He has bibasilar crackles on auscultation. He has a productive cough with pink tinged sputum. So what in the world kind of condition are we looking at here? Now this is kind of because he's showing symptoms that we know jugular vein jugular venous distension and edema in the legs and feet and swollen hands and fingers and distended abdomen are all signs of right heart failure, correct? But the bibasilar crackles on auscultation and the productive cough with pink tinged sputum are left side. So what has happened here? What has happened? What is our problem? So choose one. Is it right-sided and left-sided? Yeah, it sure is. Very, very. He's got features of both of those. And what did we say would happen if left-sided failure gets worse and worse and worse? It's going to go over to the right ventricle. So now he has problems with both sides, and vice versa. If they have bad right-sided failure, it's going to eventually cause left-sided heart failure. So this is what's happening to him. So that's a very good picture of what you would see in someone who has frequent exacerbations of his heart failure. Something he's now developed both right and left sided heart failure. So, during morning care the next day, he developed shortness of breath, fatigue, and tachycardia. How are you going to interpret these findings? And what are you going to do about them then? So, this shows you how fragile this person is. He has developed shortness of breath during his morning care, which you would be assisting him with. But what are you seeing here? How are you going to interpret this? Let's go on to the next slide and discuss this, okay? So what we're seeing here is that he has developed fatigue from too much exertion. So that's what you interpret that. He just could not handle that morning care. So what are you going to do? Well, you're going to have to arrange nursing care to provide periods of rest and any assistance with care that the patient cannot do himself. And you're going to document and observe, you're observing and documenting the client's response to this activity. And as they improve and get better and maybe get some of that fluid off, then the physical therapist maybe can help them gradually increase their activity. But these people need to be watched very carefully because they cannot do a lot of exerting. So, during the evening shift, they come and they do a bedside echocardiogram. Remember, echocardiogram is our best diagnostic tool, and that reveals an ejection fraction of 30%. Which medication will you anticipate being prescribed by the healthcare provider? Now, which one of these would we need to do? Now, remember what adenosine is. That's that medication you give very, very fast and it will slow down the heart. We don't have that problem, do we? What about lisinopril? That's an ACE inhibitor and will help the blood pressure. So, do you think they might need that? Yeah. What about lanoxin or digoxin? It helps with contracting and it also will help slow the heart rate. So yeah, that'd be a good one. What about lidocaine? Well, he's not having dysrhythmias. It doesn't say that they're having dysrhythmias, so no, no lidocaine would be necessary. What about furosemide, which is Lasix, and that is a diuretic? So looking at these drugs, it's easy to pick them out. We do not need adenosine. We do not need lidocaine. So we need lisinopril, dig, and furosemide. Those are the three drugs that you would anticipate the patient. I think I cut myself off on the other one, but these are the drugs that would be commonly prescribed drug classes for patients with heart failure. ACE inhibitors, which is the lisinopril, diuretics, and nitrates, and digoxin, and human B, the the BMP, the brain type natriuretic peptide. I can't say that word. Inotropics and beta adrenergic blockers. Adenosine and lidocaine are not indicated in this scenario, but this gives you a very neat picture of the drugs that would be used for patients who are in heart failure. So try to remember this question, okay? So looking at our question here, which assessment finding does the nurse anticipate in a client with right-sided heart failure? Select all that apply. When I look at this, I am thinking right-sided heart failure, which means that it's a systemic problem. So I'm looking for neck vein distension, and I'm looking for an enlarged abdominal girth. The other ones I know are connected to left-sided heart failure. So my answers would be neck vein distension and enlarged abdominal girth. So there you are, C and D. Right ventricular failure is associated with increased systemic venous pressures, which causes neck vein distension and enlarged abdominal girth. The other options are associated with left-sided heart failure. Okay? So we have a patient who has chronic heart failure and they've been prescribed av- ivabradine. Ivabradine is also called Corlanor. Which assessment data requires the nurse to contact the healthcare provider before administering this medication? Now, you have to first know about this medication. So, what is this used for? It's used to treat certain adults to decrease that risk that they would that their condition might worsen and they would need to be treated in a hospital. So it's given at home, and also it can be given for a certain type of heart failure in children if they're older than 6 months and it's due to cardiomyopathy. So you would tell the doctor if they had an irregular or slow heartbeat, low blood pressure, a pacemaker, or symptoms of heart failure that recently worsened, or liver disease. And if they had any of those, they would probably tell you not to take the medication, the ivabradine. So obviously our answer here is given for a low ejection fraction. So we know that that's not the answer. Resting heart rate of 80 beats a minute, that's normal. And if they're on a beta blocker, well, they probably are. So your key here is the hypotension. That is what you would notify the doctor for. So to give you a little bit more background on ivabradine, it's used for heart failure clients who have an ejection fraction of less than 32%, who are in sinus rhythm with a resting heart rate over 70. This is used for clients who are either on the maximally tolerated dose of their beta blocker therapy or have a contraindication to beta blocker therapy. This ivabradine is contraindicated with hypotension, sick sinus syndrome, third degree heart block, pacemaker dependence, severe hepatic impairment, and the use of the cytochrome inhibitors, and that means they cannot take this with any grapefruit juice or pills that contain grapefruit juice. Okay? So then question 3 is the nurse expects which outcome in a client who is taking a beta blocker for mild heart failure. So what do you intend to happen? What do you want to happen for these people? They're taking a beta blocker and they have mild Heart failure. Do you want them to have an increase in getting up at night to breathe, increased urinary output, increased activity tolerance, increased myocardial contractility? Well, they're taking a beta blocker for um, mild heart failure. Mild heart failure. Your answer is you want them to be able to do things. You want them to have increased or improved activity tolerance and less orthopnea. And that's the end of this chapter. Thanks.